Hello friends, in this video we are going to see about thyroid gland. So the contents we are going to see about thyroid gland are its introduction, structure, extent, dimensions, weight, capsule which is of two types, true and false capsule, then its parts, relation, then the supply to the gland, that is arterial supply, venous drainage, lymphatic drainage, nerve supply. Along with we are going to see about its histology, development and clinical anatomy. So first of all, we are going to see about its introduction. It is an endocrine gland which is located in the neck, which is of in front and side of the neck, and mainly it regulates the basal metabolic rate, stimulates the somatic and psychic growth, plays an important role in the calcium metabolism. So we must know its location, that it is located in the lower part of the front and side of the neck. Next of all, we are going to see about its lobes. So there are two lobes, right and left lobe, which are connected by isthmus. Next of all, the pyramidal lobe, it may project from isthmus. Sometimes a fibrous or fibromuscular band descends from the body of hyoid bone to the isthmus or to the pyramidal lobe, that is called as levator glandulae thyroid. Next of all, we are going to see about its situation and extent. So the gland lies against C5, C6, C7 and T1 vertebra and embraces the upper part of trachea. Next, we are going to see about its lobe extension. It extends from the middle of the thyroid cartilage to fourth or fifth tracheal ring, and the isthmus extends from second to fourth tracheal ring. So in this image, we are clearly see from the lobe extension that it extends from middle of the thyroid cartilage to fourth or fifth tracheal ring, and the isthmus extends from second to fourth tracheal ring. Next, we are going to see about its dimensions and weight. So the dimension of the lobe is 5 cross 2.5 cross 2.5 centimeter, and the isthmus extends measures up to 1.2 centimeter cross 1.2. So average, the weight of the gland is about 25 grams. It is larger in females when compared to males, and its size increases during menstruation and pregnancy. Next, we are going to see about its capsule, that is of two types, true and false. The true capsule is the peripheral condensation of connective tissue of the gland, and also the important feature of this true capsule is a dense capillary plexus is present deep to this true capsule. So in order to avoid hemorrhage during operation, we have to remove thyroid gland along with this true capsule. Next of all, false capsule. It is derived from the pretracheal layer of the deep cervical fascia. In the posterior border, it is so thin, and in the inner surface of the gland, it is so thick, and it forms a suspensory ligament of Berry which connects the lobe to the cricoid cartilage. Next, we are going to see about its apex, base, three surfaces and two borders, that is parts and relations of the gland. The gland is of conical in shape, so it has base and apex along with three surfaces, that is lateral, medial and posterolateral, and two borders, anterior and posterior. So we have to see the parts and relations in detail. So first of all, we are going to see about its apex. It is directed upwards and lateral. It is limited superior by the attachment of sternothyroid to the oblique line of thyroid cartilage. So it is related to superior thyroid artery and external laryngeal nerve. Next of all, we are going to see about its base. It is at the level of fourth or fifth tracheal rings, and it is related to inferior thyroid artery and recurrent laryngeal nerve. So in this image, we are going to see about its lateral surface, which is convex, and it is covered by the muscles, that is sternohyoid, then superior belly of omohyoid, then only sternothyroid, then anterior border of sternocleidomastoid. Next of all, medial surface. So this is medial surface. In this medial surface, we are going to see about its two tubes, two muscles and two nerves. So two tubes are trachea and esophagus, two muscles are inferior constrictor and cricothyroid, and two nerves are external laryngeal and recurrent laryngeal. And the posterolateral surface or posterior surface, which is related to the carotid sheath, and it overlaps the common carotid artery. So this is what I mentioned above. So in this image we are clearly see about its lateral, which is covered by the muscles, and medial, which is consists of two tubes, two nerves and two muscles. And in the posterolateral surface we are going to see about the carotid sheath. Next of all, we are going to see about its border. So there are two types of border, anterior and posterior. Anterior border is thin and related to anterior branch of superior thyroid artery, and the posterior border is related to inferior thyroid artery. Anastomosis between posterior branch of superior and ascending branch of inferior thyroid artery. The posterior border is thick and it separates the medial and posterior surface. So it consists of parathyroid glands and also thoracic duct in the left side only. Next of all, we are going to see about isthmus. So isthmus is a part which connects the right and left lobe of the gland. So this connection is isthmus. So it consists of two surfaces and two borders, anterior and posterior surface, superior and inferior borders. So in this image we are going to see about its location, that is parts and surface of isthmus. So the anterior surface is covered by right and left sternothyroid and sternohyoid muscles, then anterior jugular veins, then fascia, skin. Posterior surface is related to this tracheal rings, second to fourth tracheal rings. Upper border is related to anterior branch of right and left superior thyroid arteries. Thereby they are getting anastomosis. Next, lower border is related to inferior thyroid veins, which leaves the gland. Next, we are going to see about its arterial supply. Mainly the gland is supplied by superior and inferior thyroid arteries. So first we are going to see about superior thyroid artery. It is the first anterior branch of external carotid artery. It runs downwards and forward in relation to external laryngeal nerve. Then it gives branches to the adjacent structures and pierces the pretracheal fascia to reach the upper pole of the lobe. Then the at the upper pole, the artery divides into two branches, that is anterior and posterior branch. So this anterior branch anastomosis with the opposite side of the superior thyroid artery. That is, it descends from the anterior border of the lobe and continues along the upper border of the isthmus to anastomose with its fellow of the opposite side. The posterior branch, it descends on the posterior border of the lobe and anastomoses with the ascending branch of inferior thyroid artery. So we are going to see about inferior thyroid artery. It is a branch of thyrocervical trunk and it runs upwards, then medially, then finally it reaches the lower pole of the gland. And it passes behind the carotid sheath and middle cervical sympathetic ganglia in front of the vertebral vessels, and it gives of branches to the adjacent structures. Next, we are going to see about its 4 to 5 glandular branches which pierce the fascia separately to reach the lower part of the gland. One ascending branch anastomoses with the posterior branch of superior thyroid artery. So this anastomosis we mentioned earlier. Then it supplies the parathyroid glands. Only 3% of the individuals have this lower thyroid artery, that is also called as thyroideaimaartery, which arises from the brachiocephalic trunk or directly from the arch of aorta. It enters the lower part of the isthmus. Next, accessory thyroid arteries, which arises from tracheal and esophageal arteries, also it supplies the thyroid. Next of all, we are going to see about venous drainage. So first we are going to see about superior thyroid vein. It emerges from the upper pole and accompanies the superior thyroid artery and ends in the internal jugular vein. Middle thyroid vein also a short white channel. It emerges at the middle of the lobe and enters into the internal jugular vein. Inferior thyroid vein emerges at the lower border of the isthmus. It forms a plexus in front of the trachea and drain into the left brachiocephalic vein. And the fourth thyroid vein may emerge between the middle and inferior vein and drain into the internal jugular vein. Next, we are going to see about its lymphatic drainage. So, the gland is divided into two parts, upper and lower. So, the upper part of the gland reaches the upper deep cervical lymph node either directly or through the prelaryngeal lymph nodes, and the lymph from the lower part of the gland drains into lower deep cervical nodes either directly or pretracheal or paratracheal nodes. Next, we are going to see about its nerve supply. The nerves are derived mainly from the middle cervical ganglia. So, partly from superior and inferior cervical ganglia, and they are vasoconstrictors. Next, we are going to see about its histology. So, mainly the thyroid is made up of two types of secretory cells. The one is follicular cells and the second one is parafollicular cells, otherwise called as C cells. The follicular cells lines the follicle of the cells. It is columnar in shape while in active phase, and in rest phase it is cuboidal in shape. So the follicles contain colloid in their lumina. Mainly it secretes thyroiodothyronin and tetraiodothyronin, which is also called as thyroxine. So it stimulates the basal metabolic rate, somatic and psychic growth of the individual. Next, parafollicular cells. It is fewer and light cells, and it lie in between the follicles. It also secretes thyrocalcitonin, which promotes the deposition of calcium salt in skeletal and other tissues and tends to produce hypocalcemia. Next of all, we are going to see about its development. It arises from median endodermal thyroid diverticulum, which grows down in front of the neck from the floor of primitive pharynx, and in the lower end of the diverticulum enlarges to form the gland. Rest of the diverticulum remains narrow and forms thyroglossal duct. Most of the duct disappears soon, and the position of the upper end is marked by foramen cecum, which is placed on the tongue. And the lower end often persists as pyramidallobe, which we seen earlier. The gland becomes functional during the third month of development, and the remains of the thyroglossal duct may form thyroglossal cyst or thyroglossal fistula. So the thyroid tissue may develop from abnormal site along its course, so it is also results in development of lingual thyroids or retrosternal thyroids. Accessory thyroids may also present. Next, we are going to see about its clinical anatomy. First of all, any swelling present in the gland may be palpated from the behind. Next, removal of the thyroid, that is thyroidectomy, along with true capsule is necessary in case of hyperthyroidism, and also in order to prevent hemorrhage, we have to remove the true capsule as well. Next, in subtotal thyroidectomy, the posterior part of the lobes are left in order to prevent the risk of parathyroid and also post-operative myxedema. Next of all, during thyroidectomy, the superior thyroid artery should ligate near to the gland in order to save the external laryngeal lobe, and the inferior thyroid artery is ligated away from the gland to save the recurrent laryngeal lobe, because they are in close relation with the gland and artery. Next, we are going to see about hypothyroidism. It causes cretinism in infant and myxedema in adult. Next of all, tumors of thyroid gland. If it is benign tumor, it may displace or even compress the structures like carotid sheath, trachea. In case if it is malignant tumor, it tends to invade the neighboring structures. So the pressure symptoms and nerve involvement arises in the malignant tumors. So it causes dyspnea, dysphagia and dysphonia. Thank you.